So I am Dr. Pranamita Pujari and I am going to speak on how to approach a glaucoma suspect. If you see this case, a 44-year male patient who came for second opinion, he was on combination of brimonidine timolol eye drop for a baseline IOP of 27 by NCT with a normal visual field and OCT report. When I saw the patient was non-diabetic, non-hypertensive, family history was negative, and when I did explanation, the IOP came out to be 24 millimeter. Optic disc, RNFL, everything was normal, and angle were open on gonioscopy. And when I did PACI, it's not running. When I did PACI, I got 590 micron. So we should think whether the patient needs treatment or the patient needs follow-up. It is seen that 15 to 50% of glaucoma patients on anti-glaucoma medication, they do not meet the criteria of glaucoma. And at the same time, 50 to 90% of cases, glaucoma is undiagnosed. So it is essential to eliminate both under and overdiagnosis by identifying the glaucoma suspect correctly. Glaucoma suspect is a patient who has clinical findings and are all constellation of risk factors that indicate an increased likelihood of developing glaucoma, but you cannot label the patient as glaucoma. And it is seen that 25 to 30% of the patients attending the glaucoma clinic are actually glaucoma suspect patients. They can be open angle glaucoma suspect or angle closure suspect. Open angle can be optic disc suspect or visual field suspect or the IOP suspect or the ocular hypertension group. So vertical curve ratio more than 0.7, that patient always is not a glaucoma because 5% of normal population can have vertical curve ratio more than 0.7. And the rule which we insist isn't rule, that is followed in 70% of eyes, and that applies only to the normal size disc. If you see this is a large disc and large curve, that is also normal, and the other disc is also normal. Visual field suspect, if you see, we see some depressed point on the visual field and we start treatment. But any visual field defect appearing suddenly, it's not a glaucomatous visual field. I will discuss this later. Ocular hypertension group, we know they have open angle, their optic disc and visual field are normal. And we should see that there is no secondary cause of rise of IOP. Now, two landmark trials, ocular hypertension treatment study and the European glaucoma prevention study, they define the risk factor where a patient is at more risk for developing glaucoma. So they are the higher IOP, older age, family history, thinner central cornea, large curve disc ratio, and higher pattern standard deviation on visual field. And these are the additional risk factor also, and they develop by combining the longitudinal data of the OHTS and EGPS, this risk calculator is also developed. It's available online, but not many people use this. I also don't use it, but it's available there. Now, how will you approach a glaucoma suspect? Like we see, intraocular pressure is a major risk factor, and remember that Goldman applying tonometry is the gold standard to diagnose IOP and label the patient as glaucoma. Single IOP reading is not reliable. You have to determine the full extent of IOP fluctuation over time. And diurnal IOP should be done in all glaucoma suspects, especially in optic disc suspect patient and NTG scenario patient. Ideal will be 24-hour diurnal IOP, but if it is not possible, then one should go for a office IOP 8 a.m. to 6 p.m. Now, thinner history is another important risk factor for progression to glaucoma, and pachymetry is must for all patients at baseline. And if you do pachymetry, you will see that the ocular hypertensive patient is actually a normotensive patient, and the NTG patient is actually an open angle glaucoma patient. Now, optic nerve head should be evaluated thoroughly, and ideal will be a stereoscopic view with a 90D or 78D lens, and documentation is must. One should go for stereophotography, or if it's not available, at least document with a desk photo. And not only just see the vertical curve disc ratio, but thoroughly evaluate the optic nerve. Imaging technique is important for baseline and follow-up, and progressive analysis program help to detect the optic nerve and RLFN changes. But OCT is important for follow-up in glaucoma suspect, not for initial diagnosis or initiation of treatment. And results must be interpreted in conjunction with the other risk factor and clinical examination and visual field. Now, visual field, one should try to get at least 3 visual field during the first year of assessment. And remember that the hallmark of a glaucomatous field is progressive visual loss, which cannot attribute to any neurological defect. And if there is suspicious visual field on consecutive test, then one should try to exclude the neurological and medical condition causing the visual field defect, like optic disc abnormality, retinal abnormality, and CNS abnormality. Coming to the management part, it was seen in ocular hypertension treatment study that 90 to 95% of the patient didn't develop glaucoma over 5 years. And the NNT number needed to treat is for every 20 cases treated for 5 years, we can prevent only one progression. So individual risk assessment is important. But the patient should be followed properly, serial evaluation should be done, and patients should be educated regarding the risk factor, prognosis, and importance of the follow-up. IP should be checked every 2 months, field test every 4 months, and if there is no change, then every 6 months, and if still there is no change, you can go for yearly field test. ONS documentation is also important, and if stable, then every 6 months to annual, you can see for the progression. Now, when you will start treatment in a glaucoma suspect patient, suppose the patient gets converted to POAG patient, or there is a new appearance of the visual field defect, which is confirmed on retesting, and there is consistent myopia or risk factors are there. Now, IP reduction aim is to decrease by 20%. Treatment option can be eye drop and SLT also. Last entity, angle closure suspect, we all know their occludable angle is there more than 180 degree, and all PSCS patients don't need treatment, but they should be counseled regarding the risk of developing an acute attack. In cases where you go for laser iridotomy, like one patient, fellow eye has PAC, PACG or AAC, patient having symptoms of prior angle closure. And lastly, I will say, if the patient is ready to go for iridotomy, after understanding the risks, then also you should take the patient for laser iridotomy. Thank you, everyone. So to conclude, I will say, it's a diverse group, and it's a life-changing condition to label a patient as glaucoma. So one should exercise caution before labeling a patient as a glaucoma suspect patient.
Thank you very much.